All right, boys and girls, we are back with another edition of the Federalist Radio Hour. I'm your host, Ben Domenech. You can email us, as always, at radio@thefederalist.com. Follow us on Twitter at FDRLST. Happy to be joined today by someone who can give us a real inside look at what's going on within the world of treating the coronavirus, his own experience being one that allows him to have a very unique perspective on it. He's a general surgeon. He's also senior fellow at the Cato Institute. Jeffrey Singer is with us today. You can follow him on Twitter at Dr. for Liberty, Dr. for Liberty. Thanks so much for taking the time to join us today.
Oh, it's great to be here. Thanks for having me.
Before we get started, give us a little bit of your own background. Mostly when I talk to think tankers and people who work within the policy sphere, a lot of the time that's the only job that they've ever had, or they have some experience on the Hill. You have a much more direct experience when you're talking about health policy in America. Tell us a little bit about that.
Yeah, I'm not your typical think tanker, I guess. I'm originally, you could probably tell by my accent, I'm originally from New York. That's where I went to college and medical school. I've been living in Phoenix, Arizona for over 40 years, and I'm a general surgeon in private practice. I started off in solo private practice in 1981, and I grew it to a very large group general surgery practice. It's still going. I'm still in practice, but I've always had a deep interest in public policy as well, even back when I was an undergrad. And for many years, I was an adjunct at the Cato Institute, and I'm also a visiting fellow at our local market-based think tank, the Goldwater Institute here in Phoenix. Mm-hmm. And then about 3 years ago now, I decided to slow down my practice. I'm still practicing, but I'm sort of in part-time practice. I'm in a law practice, I guess I would be the equivalent of counsel. So yes. I'm limiting my practice in general surgery to about 20 hours a week, pretty much all elective surgery, no emergencies. And I'm full-time now with the Cato Institute. And because of my practice is still here in Phoenix, I get to be one who has been, they usually like their scholars to work in the building in Washington, but they have a few people who have situations like me where they allow me to work remote. So when the pandemic broke and the Cato Institute went to all remote working, that really didn't affect me very much because that's what I was doing anyway. And I'm back and forth to Washington regularly as needed, as well as anywhere else where I have to go for conferences or whatever in my role as a senior fellow at the Cato Institute. I'm in the Department of Health Policy Studies, where the director is Michael Cannon, and basically I bring, I hope, to the Cato Institute the perspective of somebody who's actually in the trenches dealing with real world experiences. So we're not just talking about theory, we're talking about how it really works in practice. And I bring that perspective, and I'm hoping that's complements a lot of the work of the other people there.
Well, I certainly think we've had Michael on as a guest in the past, and others from the Cato Health Policy orbit, and it's always a pleasure to talk to folks though who have that on the ground experience. Tell me a little bit about what you started seeing as America's entire health sector started to rework itself around dealing with the coronavirus threat.
Well, first, I think this is going back to around early March or so, February, March. I think it's important for a lot of people probably don't realize that the notion of, as they called it, flattening the curve was not some unique idea to people like us in practice, because every few years, for example, we get a notification from the CDC that they're expecting an unusually bad flu season. And we work as surgeons. We're in private practice. My group, we're employed by the hospital, so we have our own practice, but we go to several different hospitals, and the hospitals notify their staff well in advance, saying, "Listen, we've received some reports. It looks like it's going to be a bad season, so we want to be ready, and we will ask you to during the months of October and November, see if you could put off some of the things you were planning to do that are elective, because we may not have room, and we'll keep you posted." And they're in constant communication with us. So it's not unusual, for example, for them to say at some hospital, "Look, we're down to 5 ICU beds. We ask you for the next 2 weeks, don't do anything that's not essential, and we'll keep you posted. So when we originally told about this new virus that, since it's new, nobody's been exposed to it before, and we anticipated it was going to be an onslaught. The idea of working to decrease the onslaught so that the healthcare system doesn't get overwhelmed was not foreign to us, and I don't think there's a single healthcare practitioner who wasn't on board with that. Mm-hmm. So that's important, because a lot of people who are not in the healthcare world may think this is a new thing. This is not a new thing. Then different parts of the country, it hit differently. So for example, in Arizona, where I practice, it was relatively quiet. We were seeing these horror stories, particularly affecting the Northeast. And we were puzzled also why nearby California, which is not very far, it's a 5-hour drive from Phoenix, they didn't seem to be getting hit very hard either compared to the Northeast. In our state, our governor acted late March. He put a ban on all elective procedures. And he did some other things that I think were good things to do. For example, there was a hospital, St. Luke's Hospital, had just been closed down in October of 2019. It's owned by a private for-profit hospital system, and the hospital was not being used much. So they decided to close it down, but it was still just closed down, and he ordered it to be reopened and retooled so that it could be sort of Phoenix's version of the Javits Center in case we needed to have more beds. And all of the healthcare systems within the state were told to organize emergency plans and contingency plans, and surge capacity was made available, and people who may be retired or semi-retired were sort of recruited to be on call as a standby in case we need you. So those kind of things were very good. What I had a problem with, of course, was the statewide ban on surgery, on elective surgery, which was not unique to Arizona. It was implemented in many of the states. Mm-hmm. And a lot of people think when they hear elective surgery, they think this means something like a facelift or a nose job. Elective doesn't mean cosmetic or unnecessary. It just means that you can elect when you want to have it done. It doesn't have to be done right now. And then even among elective surgeries, there's a whole spectrum of, it may not need to be done right now, but maybe it needs to be done like in the next week or two, as opposed to this could wait months. So there's a whole spectrum, and a lot of it, of course, depends on the individual circumstance. So for example, an otherwise healthy person who has cataracts and is having trouble seeing, but's got a lot of people at home, a lot of support, cataract selective. It's not an emergency cataract surgery, but if, that might be able to be delayed a while. But if you're an elderly person, maybe living alone, and you're already having trouble seeing, and you're at risk for falling because you can't see well, and then if you break a hip, that could be the final event of your life. Well, the cataract operation is a little more urgent for somebody like that. So when you had this one-size-fits-all blanket ban on elective surgery, that had a lot of impact. Mm-hmm. And there were some parts of the state where there wasn't much of an outbreak. So you had a situation where, hospitals were empty and quiet in parts of the state where there were hardly any cases of COVID-19. And then you had other parts of the state where there were a lot of cases, and had there not been a ban, the hospitals would have, held off on it anyway. Mm-hmm. And then we had reached the point where there was about 40% capacity at most of the hospitals in Arizona, and they were laying off or furloughing nurses and doctors and other staff. So, and at that point, the pandemic really hadn't hit Arizona very hard. Finally, by May 1st, the governor lifted the ban. Well, that takes a while now, because it's lifted, now we have to get a hold of all the people that we told them we can't do anything, we'll call you back. So we had to contact them. There were a lot of people who had been calling for appointments for elective procedures. And we said to them, listen, we don't know when we're going to be able to even take care of you. If it's not bothering you that much, maybe you ought to call us back once the ban is lifted, because there's no point in sitting in our waiting room and possibly catching coronavirus from somebody else when we can't do anything for you right now anyway. So there were those people that we had to kind of now notify that we were open for business again. And besides that, there's an awful lot of fear on behalf of a lot of patients. So when we started contacting people, telling them we can now take care of your problem, a lot of people saying, no, I think I'm going to just stay home. We had a lot of that also. So anyway, we finally lifted the ban. And then sometime around the end of May, beginning of June, it seemed like the virus made its way to Southwest. And so it's almost like ready, fire, aim, or something like that, So that's sort of what we did. We put the ban in place when there was not even a justification for it. And now there's no ban in place. But to the governor's credit so far, I must say, he hasn't reinstituted the ban. Why? Well, because we're doing what we usually do in this situation. And this is what I've argued in my writings about this. This is best handled on a local level by the people dealing with it with local knowledge, and not even in this one state, not one size fits all. There are parts of the state or even parts of the city that are less impacted than other parts. So, for example, my group, we use there are two hospital systems that we perform surgery at. One is a 5-hospital system. The other is a 7-hospital system in the metropolitan Phoenix area. And there are others as well. Well, one of them has really gotten filled up. They have they have a couple of trauma centers in their system. They have a lot of really state-of-the-art critical care capacity. And for that reason, they've accepted a lot of referrals from other parts of the state. Parts of Arizona are very remote. There's the Navajo reservation and other Indian reservations where people actually have been hit hard. They are underserved anyway. That some of them are very poor health care to begin with. So they've been bringing them into the city, and a lot of them have been going to that health system. So that health system started off by saying, we're going to keep you posted, but as of now, we can still do elective surgery. And then from there, it went to, if you're going to do an elective procedure that you think will require being in the hospital more than 2 days, hold off on that one. If it's just outpatient, it's okay. And now, as of last week, they said any elective procedures already scheduled, we'll let go through, but please don't schedule any other until July 27th. And then every week we're taking a reassessment and we'll update you. So on July 27th, we may extend that, or we may get in touch with you before July 27th and say, actually, it's leveling off. You could bring in patients now. That's one of the systems. The other system hasn't been hit as bad. So they haven't asked us to curtail any elective surgery, except surgery that we think might need to be used, might need to go to the ICU after surgery. That's the only surgery they've asked us to hold off on. Because some procedures like coronary bypass surgery, you need the patient in the ICU post-op for 1 or 2 days. So if it's an elective one, they ask you to hold off on something like that. So again, that's what I think it should be. It should be a case-by-case basis. This way, when things loosen up and you could bring in more elective procedures, you don't have to wait for one person, whether it's the governor or the state health director or whoever that may be, to make this one decision for all these different localities. And not only that, but when you have all the decisions placed in the hands of one person, then you set up an incentive structure that, again, it doesn't matter who this person is or what their political party or ideology. If they open up, quote, too soon, and all of a sudden case numbers start going up, which is all that the general public hears about. They don't hear about the other details. Well, then it's on the governor. And whereas what's not seen by delaying the opening up is all the people who aren't getting necessary elective procedures, for example, or the people who are, foregoing cardiac catheterization, which is an elective procedure that could detect a heart problem that may be a ticking time bomb that's not getting done, for example. That stuff isn't seen. So you're already putting into place, when you put the decision-making power into the hands of one person, you're putting into place an incentive structure that's going to make them err on the side of being more cautious than they have to be. And that's going to hurt people.
Well, so you said a lot there. One of the things that I think you have identified there is something that a lot of Americans are witnessing right now as it goes to the debate about reopening schools, K through 12 for children in daycares, where the media basically is demanding something, and they demanded it this weekend of Betsy DeVos, the education secretary, that can't be promised, which is essentially, can you to rephrase it, to put my own spin on it, it amounts to, can you guarantee that no teacher or child will get sick from reopening the schools? Which is, of course, ludicrous. You can't guarantee that. What we do know is that, this is actually much less dangerous for these youngsters than certainly the flu is, and many other diseases are. And that's something that localities have to weigh and decide upon. But again, the media is demanding a national plan, a nationalized one-size-fits-all plan when it comes to those reopenings. When you see that type of conversation play out, how do you want to interject your own case for why these issues and decisions need to be at a much more localized level, why they can't be one size fits all?
Well, it happens just on a daily level when I'm discussing an elective surgery with a patient of mine. There's not a single thing that doesn't have a risk and a downside. Every single thing we do. When we decided to raise the speed limit from 55 miles an hour to 75 miles an hour here in Arizona, well, that means if you decide to go above 55, you may be taking a greater chance that you'll die in a car accident. We make these decisions every day, and nobody can guarantee an outcome. So when I'm discussing the risks of the procedure with my patient, I have to let them know that, this could happen, that could happen. This is very uncommon. It's extremely rare, but this can happen. I can't guarantee that you won't be the 1 in 1,000th person this will happen to. I got to let you know that, and you have to make your decision. And if some people decide, well, even 1 in 1,000 is too risky for me, well, who am I to impose my, risk aversion level on that person, whatever. So it's the same thing with schools. What we know about K through 12 school right now, there are about 20 countries that have had schools running since about April. Some countries never close the schools, like Taiwan never closes schools. Sweden never closes schools, but it's been open in the Netherlands and Germany and France and the UK. What we've learned is that, generally speaking, again, this is generally speaking, there's always an exception. It seems like children under about the age of 11 or 12, so let's say K through 6, not only are they very unlikely to contract the virus from an adult or from one another, but they're also highly unlikely to spread it to an adult or to bring it home or to other children. That's what the data suggests. Now, there are exceptions. There were 2 instances that were reported, one in Quebec and one in Israel, where there was an outbreak. But the overwhelming majority of situations when we're dealing through K through 6 is that it's been remarkably safe. In fact, about a little over a month ago, the Royal College of Pediatricians in the UK encouraged that they open the schools for young children. And then just a couple of weeks ago, the American Academy of Pediatrics did the same. Now, the other day, the American Academy of Pediatrics co-signed a letter with the Teachers Union and the National Public School Superintendents Association. I forget their exact name, but it was portrayed in the press as a, quote, walk back, but it really wasn't a walk back. They just simply said that these decisions need to be made on a local level based upon the input of the parents, the local public health officials, and the school, the educators. And I'm totally on board with that. One size does not fit all. And obviously, it stands to reason intuitively, if you're in an area where there's a huge outbreak going on at this moment, there's going to be a tendency for you to want to move slow on anything, because there's a huge outbreak going on, as opposed to in an area where it seems to be settling down. So that really wasn't a walk back. It was more of a clarification, let's say, to make sure that they're not misinterpreted. But that's what the evidence shows. Now, when you're dealing with older children, like middle school and high school, they're still much less at risk of contracting the illness. And of course, they have much better outcomes, but they seem to be more likely to spread. So we're talking about young kids, like K through 6. And then the other thing is, and pediatricians will tell you this, at that age range, K through 6, there's a lot of trade-offs, because these children don't tend to do well in the remote learning situation. Yeah. They do much better in classroom. And there's also not just cognitive developmental milestones that they have to pass, but there are socialization skills. I mean, a whole lot of stuff is they're very important to experience, like on the playground, or, negotiating and arguing with your fellow little kids. This is all part of learning how to be a person. And some of these things are critical. So you could make an argument that that's a public health trade-off as well. So you're trading off the risk of your child contracting and bringing home the virus against the risks of them missing out on some very crucial portions of their development. Whereas when you're dealing with a high school kid, that's less of a role and they do better online. So you can make an argument of, and then some countries have done that. They've let the little kids go to school, but they, like in Sweden, the high school kids are learning remotely, but the K through 6 kids are learning in school.
Mm-hmm. There's also trade-offs, of course, in the health sphere as well. I mean, when these lockdowns started rolling out and people were told that they were going to last 2 weeks or so, there was a different attitude, I think, in terms of expectations about the levels of opioid abuse that we would see, of internal, sadly, bad family dynamics, and both abuse and sexual abuse and things of that nature. I know that there has been, while we don't have a ton of data on all of this in the last couple of months, we do have some, and a lot of it looks pretty bad, particularly on the opioid front. Can you talk a little bit about that trade-off that was part of this as well?
Yeah, but also with the little kids, the pediatricians will tell you that that the little children being stuck at home are much more at risk for child abuse, which is oftentimes detected by the teacher in the classroom who's trained to be able to detect that. And now, of course, there's no ability to do that. When it comes to the opioid situation, well, first of all, people who treat addiction will tell you that people trying to overcome addiction need connectedness. It's a very important part of overcoming addiction. In fact, a lot of people now think that substance use disorder, whatever the particular substance is a kind of a learned coping mechanism. It's automatic. It's almost an unconscious coping mechanism that one has developed. And almost everyone, the great majority of people with substance use disorder have psychological comorbidities that helped that happen. So the last thing in the world you need when you're trying to overcome addiction is to be isolated and have no connectedness with anybody. That aggravates the situation. So even though some efforts have been made on the federal regulatory level to make some of these addiction treatment programs like methadone or buprenorphine programs more, they waived some of the tight regulations so that people who are receiving this could still receive it. But that's just a part of the equation. When you're alone and you isolated, and you also a lot of times don't have much to do, that predisposes to backsliding. And we're seeing that. We're seeing more and more cases of clinical depression. We all know alcohol sales are up through the roof. That's another substance that people can have substance use disorder with. So, Aristotle said man is a social animal. And I think every one of us can attest to that now. When we get a chance, those of us who've been living in parts of the country where we're particularly under shelter in place orders, and we get a chance to interact face to face. It's not the same as on Zoom. When you interact face to face with someone, you feel almost exhilarated that you had that chance. And then you realize how much we actually have a psychological need to be with other people.
We have seen the fight go on over the health expertise that is being displayed at the highest levels of government, but also within the media landscape. I'm curious as to your perspective on this, because one of the things that I think is missing a lot of the times when we talk about health subjects, especially ones that are as challenging as this one, is that you can't expect health experts to be miracle workers or to know everything about something from day one, that their knowledge is going to evolve as new information becomes available, that they're not going to necessarily get every call right. And yet, I think in this circumstance, there was clearly a pretty hefty blow given the shifting attitudes about lockdowns, mask wearing, and the attitude, I think, particularly towards schools right now at the moment, where the different health experts that are out there and talking on television, where they disagree, people tend to run to their partisan corners based on what they want to achieve and what their priorities are. How would you tell people to think about the health experts that they see on TV when they're giving advice or when they're talking about how they're guiding policy?
Well, I think there's a tendency when everybody wants results quickly, all of us do. We're impatient. We want answers. So there's a tendency for when a health expert states what he or she thinks is a fact, for everybody to latch onto that, and that suddenly becomes the headline of the day. And masks are not necessary, or masks are necessary, but I guess it's maybe because I've been a doctor for 40 years. I understand that when a health expert tells you something, that's not the Oracle of Delphi you're hearing from. That's a person giving his best opinion based upon what is known right now, and that there are other people equally intelligent and knowledgeable who may have a different opinion, because that's what we do. We pick up a medical journal and you're reading conflicting opinions on how to treat a disease within the same issue of the journal, or you go to a conference and you're seeing different experts debate. So when I hear a healthcare expert say something, I'm understanding that this is not locked in stone. But I can understand how people, particularly when you're frightened and you want answers quickly, you tend to latch on to every statement as that's the gospel. On top of that, there's been a tendency on behalf of, I think, all of our political leaders to just turn everything over to the public health officials.
Yeah.
And it's hard for me to say this because I'm a doctor, so I don't want to say anything against my profession, but don't ask a doctor, for example, for investment advice. Ask them for health advice.
Yeah.
So I think a lot of the leadership on all the levels of government have really defaulted. They really haven't done what they should have done. They should have asked. This is a decision that is multifactorial with multiple trade-offs. So you need your healthcare experts to tell you that these are the facts. What are the facts about this disease? What can we expect? What are the things that you think can be done to mitigate it? And then you say to for example, your economic experts. So you heard what the health experts said. What do you think about what are the pluses and minuses of their recommendations? Mm-hmm. And then you also need to talk to your political people and say and ask them, what do you think are the likelihoods of getting the public to go along with what they're recommending? And then you, as a leader, you got to put it all together. It's not like they say, I'm going to trust the science.
Yeah,
that's code for I'm going to let the doctor make the decision. It shouldn't. You're going to make the decision.
It's a total can kick. And it's
right.
not responsible because, leadership requires putting all these things together. I worked for about a year at HHS under George W. Bush, under Tommy Thompson. And I can tell you, what you've said about health experts is absolutely 100% true. They're telling you the best thing that they can with the best knowledge that they can about that they have about the situation that's in front of them. But they're only speaking to the health issue. They're not speaking to what that does to the economy or what it does to, a lot of these other long-term problems that we've already mentioned. And to me, I think that was the real, frankly, and it's been bipartisan, I think, failure of leadership that we've seen across the country in a lot of these states where these decisions were made either by kicking the whole responsibility over to the health experts or by, frankly, overreacting to some of the things that I think they saw in ways that ultimately proved very damaging. I think that that's the true story about the situation in New York with the nursing homes there, right. Which is so tragic and has contributed so much to their death totals. In Arizona, I'm curious what you're seeing. We've seen some criticism of the governor from the mayor of Phoenix, though she seems to have walked some of that back. And it's currently getting a lot of attention as being a current hotspot in terms of caseload, though the death toll is clearly much lower than what has been experienced in major parts of the Northeast. Florida as well is another area where that kind of thing is happening. There's a lot of controversy in Texas. Tell me a little bit about the Sun Belt's experience with this, and particularly what you've seen in Arizona.
I can't tell you about the whole Sun Belt, but I could tell you about Arizona.
Sure.
Well, first of all, the hospitals, for the most part, are really crowded. Like I said, some are worse than others. It's the last few days I've been monitoring it. It seems like it might be plateauing.
Mm-hmm.
It hasn't gotten any worse, let's say that. It's not getting better, but it hasn't gotten any worse. So they're running about statewide 89% ICU capacity and about the same 85, 86% regular bed capacity. They haven't had to use any surge beds. The hospitals are readying for that. Several of the hospitals have already gotten beds ready and converted certain parts of the hospital that are not used for patients in case they need to have overflow for that. But it hasn't gotten to that point yet. Some hospitals are transferring patients from one hospital to another within the system where there's more room. And so they're working things out. Arizona's a kind of, we're kind of culturally a little bit of a rebellious state. Like if you want them to do the opposite, then tell them what you want them to do. So there are a whole lot of people that I have seen who intentionally are not wearing masks because they were told to.
Yeah.
So got some of that. You got a lot of young people who, when the governor relaxed things, particularly in Scottsdale, there's a great bar and nightlife scene. And the bars and clubs were packed like they've always been. Nobody was making efforts to social distance. And that's contributed greatly to the surge we have here, because it looks like something like maybe close to half of the new cases are all young people. Mm-hmm. Now, the good news about that is the young people are much less likely to require hospitalization. In fact, according to the government state's data, 5% of all cases require hospitalization. Mm-hmm. So it's important to keep in mind that 95% chance if you get infected, you're not going to be sick enough to go to the hospital. So that's the scene here.
Can I just interject something on that? One of the conversations about this that I find so skewed in the way that the media treats it is this idea that government lockdowns were going to be something that could be permanent or could be sustained until a vaccine is found, if ever. To me, the research that we have on this essentially tells us that after a little more than 2 weeks, and certainly by about 4 weeks, people start to rebel. They do not obey these types of things in a sustained way. And we lack the policing power to make them do that. Like, I mean, you would need the whole National Guard would need to go to Arizona to keep those folks from going out there and seeing each other after a certain amount of time. And so I think that there's this kind of fantasy land that the media holds up where everyone locked down for the exact amount of time and at the exact moment and in the exact ways that could have prevented these deaths or prevented these caseloads, certainly. And I think that's a fiction. I just don't think that that's something that would be possible.
I also don't think it's realistic. I actually had a conference at the Cato Institute in the beginning of June about this. I'm speaking for myself. I see all these arguments take place among people with whom I'm friends, about different studies, and they argue the methodology and the statistics and all that kind of stuff. And I'm thinking, I hate to say this, but I was a biology major, and I purposely was not a math or chemistry or physics major, and biology is maybe a softer one of the hard sciences. So all I know is biology, and biology tells me this virus isn't going away. The measles hasn't gone away, polio hasn't gone away. The only virus we've ever eradicated that affects humans is smallpox. And that was when everybody was forced to get vaccinated. And right now it's in a laboratory, and if ever it gets out, we're in trouble because it's been a couple of generations since people got immunized to it. But the point is that if people think they could stay locked down until the virus gets bored and goes to some other planet or something like that, they're mistaken. That's not how it works. Mm-hmm. So, and there's no guarantee that we're going to get a vaccine that's effective. We've been trying for more than 20 years to get a vaccine against HIV and hepatitis C, and we don't know how long it'll be effective and how often we have to get it. So it'll be great if we can come up with some medications, and I think that is maybe more important than putting all your efforts on a vaccine. Although we should go for a vaccine, but we shouldn't neglect trying to come up with a medication because we may not get a vaccine. But the bottom line is, I think we need to learn to adjust to the fact that there's a new member of our ecosystem called COVID-19. And so as we learn more about it, we could learn to live with it like we've learned to live with a whole lot of other diseases that are commonplace, and practice harm reduction.
Yeah. So that's been something that Ovik Roy, who I'm sure you're familiar with his work, has been advocating for at FreeOp. And seeing the amount of flack that he got, which didn't surprise me, for saying, essentially what you just said, we have to learn to live with this, was something that I think revealed a lot of how much people have gotten it in their head that there is going to be kind of a snap your fingers solution that makes this vanish or go away or go to the moon. And that's something that we should really work against, because it will lead to a lot of bad policy decisions, I think, and bad assumptions on people's parts about what life looks like. In terms of just finishing up this conversation a bit, what would you be advising people if you're sitting down at the kitchen table with them? They're looking at this circumstance where they're unsure about their jobs within this economy, whatever work they do, if they're working or middle-class American. They're unsure about whether their kids are going to be able to go back to school in a real way, where they're going to be able to socialize and learn, as opposed to just sitting down in front of a laptop and seeing all that stuff stagnate. They're worried about the health side of things, particularly as it relates to, not just elective surgeries, but to undiagnosed illnesses. All these people who are avoiding checkups and the like that they would normally get. I'm way overdue for my just general physical myself, I have to say. And so it's one of these things where all these people are making determinations and trying to navigate this in a climate in which we have this highly politicized, very aggressive battle playing out in the media that puts all these things into red versus blue and the like. As you are sort of thinking about this, what advice would you give to people who are confronting these on having a broader perspective and maybe a note of hope or optimism?
Well, that we had a conference on June 3rd called Harm Reduction as a Public Health Strategy for Pandemics. I moderated the conference, and that was the actual point of it. At that conference, we had Maya Salovitz, who's an expert in writing a book on the history of harm reduction, which of course we usually associate that with dealing with substance use, needle exchange, that kind of thing. And then I had Lena Wen, who is a public health professor and emergency physician at George Washington University. And what I was trying to point out is the same attitude behind harm reduction that we use with substance use or with sexual activity. It's the idea that you're not going to have a completely drug-free society, and you're not going to have a society in which everybody is abstinent sexually. So let's try to make everything safer and less harmful. That's the idea behind that. When we need to have that same realism when it comes to this virus. This virus is not going to disappear. It's not going to get bored because everybody's locked down and go to another state that isn't as locked down. So let's start asking ourselves, what are the kinds of things that we could do to make living with this virus in our environment less harmful to all of us? And of course, things involve much we need to protect, and we're starting to do that now, learning how to protect people who are more vulnerable, nursing home patients, which we were neglecting before, people with whom we live in our family who might be have more pre-existing vulnerabilities. Either they don't even have to be elderly, but usually they are. When it comes to school, I mean, I have grandkids, and I tell my children, who are the parents of those grandkids, that I think they should send their kids to school. I mean, they're 3 and 5. I think they need to go to school. But on the other hand, even though people don't like to wear masks, and I personally, I don't like mandating masks, because as a libertarian, I don't like mandating much of anything. But I recommend wearing a mask when you're in a public setting. Now, when you're walking down the street out in the open air, you don't need a mask. Enjoy the fresh air, breathe it in. But when you're in close contact with someone in a public place and you don't know whether they have it and they don't know whether you have it, Masks are not 100% protection, but they reduce your aerosol droplets on them, and and vice versa.
Mm-hmm.
And so it's just consideration, being a good neighbor. So, and same thing, if just like we do with other viruses, if you're invited to someone's house for dinner or whatever, and you feel like you may be coming down with something, you should, I would hope, say, I better bow out. I think I'm coming down with something and I want to give it to you. Well, that's the kind of behavior we should have. And hopefully, if we do that, we'll mitigate the harm. A lot of us are going to get sick, but every flu season, a lot of us get the flu. Most of us feel like crap for a few days, but then we get over it. And it should be reassuring to know that as the more we're learning about this virus, the more we're learning that it's not nearly as deadly as we thought. Its fatality rate is going to be somewhere maybe in a 0.4% range, and mainly skewed towards the elderly and vulnerable people, which is better in certain respects than influenza, which seems to be less sparing of the young, healthy people. And so we're going to continue to learn how to do things to avoid us getting harmed by it as much as possible.
Dr. Singer, I want to thank you so much for being so generous with your time. I hope that you'll continue to write about this, obviously, but that you'll also come back and join us again in the future so that we can talk about this more. Thanks so much.
I love that. Thank you. Bye-bye.
I'm Ben Domenech. You've been listening to another edition of the Federalist Radio Hour. We'll be back soon with more. Until then, be lovers of freedom and anxious for the fray.